But I do want to get on to our final speaker. We're exactly on time, and we're very lucky to have from, I think, the wee hours of the morning, we've got Assistant Professor Anne-Grete Martson. Anne-Grete is an assistant professor at Leiden University in the Netherlands. Anne-Grete Martson Research Group focuses on optimizing antiviral and anti-infective drug dosing and therapy using computational and laboratory methods. They focus on the drug exposure response relationships, i.e. PK/PD, to investigate what are the optimal targets for efficient therapy with the least toxicity and preventing the development of drug resistance in viral infections. They conduct clinical studies, laboratory experiments, including hollow fiber infection models, and use computational methods, PK/PD, PBPK modeling, to find the best treatment regimens and translate results back to the clinical setting. So we're really excited to hear your presentation today on precision dosing in obesity. It's one of the most common questions I think I get asked as a clinical pharmacist, and really interested to hear what you have to say. And thank you so much for making time for us this morning.
Thank you so much for the nice invitation. I worked as a clinical pharmacist for some years in the ICU, so I totally understand the question. So I hope I can answer some of them that you might have. So yes, today I will talk about precision dosing in obesity. I will dive right in to the topic. So when we look at patients with obesity, we do expect changes of the increased body size. So basically, we have a larger body due to the weight change, and this is likely due to increased body fat. So all over the body, we will see more body fat than in a lean individual. There is expected changes in kidney function, and also fatty liver has been related to patients with obesity, and increased blood flow in some organs. So this can cause different changes in the pharmacokinetic exposure, so drug exposure in patients. So what we do see and what is known is that for patients with obesity, there is an increased volume of distribution. So the distribution of drugs will change. There is delayed gastric emptying. So that means that we expect the drug exposure to go down to a certain drug that are affected by the difference of volume of distribution. And I will come back to that briefly. Obviously, there is also changes in kidney function, and that can be in both directions. So there could be an increased kidney function or a obesity-related kidney failure. That means that the exposure of the drug can change either higher or lower. So we do also have changes in cytochrome P450 function, meaning that many drugs are metabolized through the system, so we can see changes in drug exposure. And there can be an increased absorption of lipophilic drugs and reduced hepatic metabolism, meaning that the drug exposure can go up. So if we look at a lean of the composition of the body mass of a healthy adult, you can see that around 85% of the body mass is a lean body weight. So meaning that is cellular compounds and water and minerals, and 15% of the body mass is fat mass. So if we look at patients with obesity, this tissue distribution actually don't change linearly in patients with obesity. So, for example, the mass of the muscle increases less than the adipose tissue because the higher total body weight is related to fat tissue increases. So high weight in obesity is mainly linked to the fat mass increase. And very briefly, I want to show you this nice figure from this nice review article of Goju and Ligay. So on the left side, there is a theoretical weight evolution according to total body weight. On the right, there's according to body mass index. And basically what you can see in this figure is that, well, obviously the ideal body weight we try is stable here. And the adjusted body weight, which is here the AGBW, is increased linearly. However, the lean body weight and the fat mass increase non-linearly. In patients with obesity, the proportion of total body mass is more related to the fat mass. And here you can also see the relationship of the fat mass to total body weight increasing or with the increase of the body mass index. So it is really important to think about these drugs that are poorly water soluble, and the drug solubilization and absorption will change drastically in these patients. So looking also briefly at the volume of distribution. So the volume of distribution is increased in obesity, especially for drugs that have substantial distribution to adipose tissue. So here on the top side, on the left side, you can see a lean individual. On the right side, there's an obese individual. The dashed line represents then the degree of adiposity. And so if we have on the top part of the figure, we can see a drug that does not readily distribute into adipose tissue. The volume of distribution does remain similar. If you have on the bottom side, if you have a drug that readily does distribute into adipose tissue, you can see that the volume of distribution will markedly increase in obesity. So here, the distribution of the drug will extensively change for patients with obesity. So there is also a discussion about the hepatic first pass effect, which is here then the HPFE, and there is debate that the reduction of the CYP3A4 activity does change the metabolism of drugs, especially for drugs that are highly metabolized and through this enzyme. And we can expect that some prodrugs will be affected, like the formation of active drugs from prodrugs will be affected, and also increase of some active drugs. And this can be also seen in the intestine, in the stomach and gallbladder. There is some effect that is on bioavailability that is expected. So we can expect a lot of exchanges. I think I've set the scene quite long now. So I want to go to a systematic review that we conducted with the help of a large group of co-authors from different societies. EPASC from ESCMID, the European Society of Clinical Microbiology and Infectious Disease, but also the ISEP Society and the SIDP Society. What we did then, we screened all pharmacokinetic studies in obesity class. BMI above 30 and BMI above 40. We did find many studies. We screened 4,654 studies. We ended up with 124 studies, and just checking what, yeah. So, and the most common drug was beta-lactams and glycopeptides. However, we'll come back to that briefly. The certainty of evidence is quite low. I think the previous speaker put it quite well. Many of the studies are single-arm retrospective studies that are not randomized, and more of like case-by-case examples of what is the experience. However, this is the best we have, so we tried our best to draw up some conclusions on these different drug classes. So we did, here's a short overview of what we had. You can see quite interestingly this range of different antibiotics we saw. So very briefly, some definitions could have come earlier, but just briefly. So total body weight sometimes is also absolute body weight, but we use the total body weight is the actual measured weight. The ideal body weight is an equation based on height and sex. Here is some examples, but there are different formulas available. And adjusted body weight is then using ideal body weight with a fraction of the weight difference between total and ideal body weight. So here is the ABW that we used. Adjusted body weight shouldn't be mistaken for absolute body weight, which is then in that case a total body weight. So adjusted body weight is indeed based on the ideal body weight equation. So going into specifics, drug classes, we had 11 dosing of aminoglycoside studies. So in patients with obesity, what we saw is that if to use the total measured body weight, there can be expected of toxic levels in patients with obesity, and using ideal body weight, there could be a subtherapeutic levels in patients with obesity. So what is our recommendation? We recommend to when trying to optimize the maximal concentration, weight-based dosing are using absolute body. I just made the mistakes that I said you shouldn't. So using adjusted body weight is recommended. In order to optimize the AUC for more maintenance dosing, the dose and dosing interval should be based on renal function and TDM rather than body weight. So this is what we concluded. And keep in mind that, these are 11 studies. We have a very detailed overview of all these studies in our supplementary materials if you're interested. So for vancomycin, by far the most studies that we saw, 26 studies for vancomycin, we did see, as I said previously, that we do see that volume of distribution increases with body weight, as is expected. However, this is not linear. So we cannot draw a linear relationship between increase of the body weight and increase of the volume of distribution. So we do recommend loading a dose of 20 to 25 milligrams per kilogram total body weight with patients in severe obesity. Patients with severe infection, when it is a deep-seated infection, severe infection, ICU patients. And the maximum dose, of course, is important because the patient can weigh much, can have extremely high weights, and their maximum capped dose is important. So dosing individualization with TDM is obviously known. And also like today was also talked about MIPD. It is important. Some years ago, there was a dosing guideline that recommended AUC-based dosing for vancomycin. And in order to do that, we do recommend using population PK models to guide the dosing for these patients. And we see that this does often end up in better target attainment for these patients. So for other glycopeptides, so lipoglycopeptides and oxazolidons, for linezolid, we found 11 studies. And we had sparse data. As I said, some of these studies are single center retrospective studies. We did see that body weight is a better determinant for pharmacokinetics than BMI for patients with obesity. And there is a lower target attainment for patients with body weight above 100 kilograms and normal renal function. So higher dose might be recommended in these patients. For dedisolic and daptomycin, there are very limited studies available. We do not recommend a dose change, again, based on very limited studies. And for daptomycin, we recommend using adjusted body weight. So beta-lactams is the next class I wanted to touch upon. By far the most studies. However, this is misleading because we did have a lot of studies in beta-lactams, but there is a large range of beta-lactams that we saw. The most common was gefazolin, used for surgical prophylaxis, obviously. So we did see quite a lot of studies there. We do see that the pharmacokinetics is frequently altered in patients with obesity. And while sometimes, mostly we do see low drug exposure, a lot of these studies conducted population pharmacokinetic analysis and also target attainment. Often standard dosing is sufficient to reach target attainment. However, because of the low exposure, we do recommend we don't recommend higher dosing in mild and moderate infections. However, in critically ill obese population, prolonged or continuous infusion of beta-lactam should be considered, and higher or more frequent doses of cephalosporin for surgical prophylaxis could be beneficial particularly for longer duration of surgeries that go above 2 to 3 hours to achieve better concentrations. So quinolones, we did have only 9 studies, and there is quite conflicting results for ciprofloxacin. There is variable PK between different studies, and we do recommend dosing based on total body weight. So we do see that up to threefold higher maximal and minimal concentrations result in similar soft tissue concentrations. Moxifloxacin PK, we did see that this was unaltered, and for levofloxacin, the AUC was highly variable. So what we recommend is not to use total body weight, however, ideal body weight and estimated renal function for the dosing. For deep-seated infections, again, higher, more frequent dosing should be considered. Lastly, we had a few of these other antibiotics. So for fosfomycin, again, for longer duration surgeries and deep-seated infections, higher or more frequent dosing is recommended. But the digoxin and tetracyclines, there is limited data. However, we do not recommend dose adaptation. So this is a lot of information. I want to reiterate that we have a very nice supplementary material section with a very long overview of all the studies that were there. You can also see the changes per study, changes as compared to normal weight individuals and obese individuals, which is another supplementary table. And we have also very small short table on outcomes. So I do recommend you look into this if you're more interested. So as I said, we have a very variable set of studies because the design of the studies is often retrospective or small center or post-hoc analysis. We do see that beta-lactams are very commonly studied, while there are many compounds. We do see that in critical illness and augmented renal clearance, likely higher exposure is needed for these patients. There are emerging new studies that are quite interesting, that use PET scanning to see where the body fat lies in the body. This is by Professor Amit Bai. Quite interesting studies emerging that could, in the future, potentially inform our dosing better. We also have studies to measure tissue concentrations using microdialysis, so using free drug concentrations. These studies are also emerging and quite interesting. We obviously didn't have strong enough studies to or comparable enough studies to use a meta-analysis. However, we are looking into, for a next step, to do a patient-level analysis and meta-analysis in order to truly be able to do some patient-level analysis. So I want to thank you all, and also thank you all to my co-authors to have helped with this study. Thank you.
Oh, that was fantastic. So practical and really highlighting precision dosing in this group of patients. Also, I really loved your focus on kidney function. And, it's not just all about the weight, but actually you can still have a spectrum of kidney function within this patient group. So you don't have to automatically start thinking, oh, you've got to think what are the drug characteristics in this patient group.
Absolutely, absolutely. And I think we have to think about just in general, what is obesity and what do we
Yeah.
see in other and what is the drug, and not only about high weight, high dose for
Yeah.
sure. Yeah.
Brilliant. Now, I actually do have two questions, one for Kelly and one for you and Brett. I might ask Kelly's first. So the question was about the high dose daptomycin that's recommended for infective endocarditis or enterococcus at 12 milligrams per kilogram. Might start hitting AUCs around 1200 or 1400, which is about at the toxicity threshold. So I guess the question is, really, how do you deal with the toxicity risks with those high doses that are recommended for enterococcal infections or IE?
Look, and I think it's a really good question, and I think at the end of the day, I don't think we know the answer to this yet. I suppose the data I've presented today is a very small number of studies, which probably reflects where daptomycin is in the precision dosing journey, which is early days. I must admit, my institution, we regularly use doses of between 10 and 12 milligrams per kilo of daptomycin, and as I mentioned, we largely use it in an enterococcal population. But our rates of adverse effects, I'll be honest and say, I think over maybe 15 years where daptomycin has been involved in therapy, I might have seen 2 cases of suspected eosinophilic pneumonia, and we've also had pretty low rates of CK rises. So I think the jury is still a bit out. I think we obviously have to continue to monitor for it. But I think hopefully there's some things I'm working on at the moment which maybe might give us some more insights into the enterococcal population. But I think at this point in time, we just don't have the actual real world data. As I said, those targets for VRE are still, we don't have clinical data to support those yet. And so I think I acknowledge that, yeah, absolutely, we're hitting the exposure thresholds for toxicity using those high doses, but with concerns around efficacy of daptomycin, we need to use those high doses. And in a patient population like mine, which is hematology patients, nobody really wants to use linezolid. So we don't have a lot of other options. And so I think at this point in time, we need to monitor and all come together as a group and start working to try and answer these questions. Because I think it's a good one that I don't have a direct answer for at the moment.
Yeah, brilliant. And as you say, if you've got to give the big dose to cure the infection, you've given us some strategies. We could be at least doing a trough concentration. I'm sure eventually we'll have a pop PK model where we'll be able to do an AUC. And if we are at the toxicity threshold, we could, be scaling our doses back and be doing a bit more precision medicine. I guess that whole question actually really is just about the fact that when you don't do precision medicine, you're at risk of problem because, you give someone a dose and it might be too much. So I think that's really realistic. Now, Anne-Grete, we've got a question in the chat for you. The question is, what about lean body weight? And I think Daniel, feel free to give a wee bit more context. I think it might have been generally, but also the Australian guidelines for aminoglycosides have moved towards lean body weight as a dose descriptor across all weights. And I think that paper was mentioned in your review, the lean body weight paper, but that there are other data, of course, for adjusted body weight. So maybe if you wouldn't mind just talking about lean body weight in aminoglycosides.
So
Yeah. Right.
I think indeed, because a lean body weight obviously includes BMI, and also there's the sex differences being taken into account. I think the main issue here is that it's not consistent across studies. So what we did see is that there is like largely adjusted body weight, ideal body weight, and total body weight, and lean body weight was just not that commonly used, only more specialized studies. So that's why we kind of tried to draw a recommendation based on that. So for obviously for having a glucoside, that could be the case that it is more used. But we just try to kind of go with what the data or what the kind of studies showed us, and just not introduce too much variability or heterogeneity on the kind of like recommendations that we had.
Yeah, brilliant. And that's what happens sometimes, isn't it? The data
Yeah.
just swamps, and so you sort of have to go with what's been most well studied.
Exactly.
Okay, well, with that, I think we've So Daniel said, so should we use lean body weight or adjusted body weight for aminoglycosides? Now, unfortunately, Anne-Grete,
So
our national guidelines say lean body weight. So
yeah, so then it's lean. Yeah, exactly. And I think they're not that far apart, right? So I think it's not like they are that they're both ideal body weight. Ideal body weight is quite drastic, right? So or total body weight is quite a difference. So I think you should go with your local guideline for sure.
and the other thing which you'll also be able to conceptualize is the lean body weight guideline, the lean body weight based dosing for aminoglycosides that's gone into our national guideline. We did slightly increase the milligram per kilogram dose of the aminoglycosides. So sort of accounting for the fact that sometimes lean body weight is a little bit lower than adjusted body weight. So the two are not real. I sort of think of the two as similar to you. They're both not total, which we pretty much know total is wrong. It gives patients too much.
Yeah.
And then we need to work out, at what scaling back level are we going to do. If you're doing actual body weight and adjusted body weight, I think you're accounting for obesity really nicely. And then alternatively, you can use lean body weight at a slightly higher milligram per kilogram per dose across the whole weight spectrum.
Absolutely.
So I don't think the two scenarios are that different, similar to what you said. Exactly. Yeah, great. Daniel, feel free to to ask again if we've not chosen a side enough. But I would really like to take this opportunity to thank the all four presenters, but the three that are left. Wonderful job. We really appreciate it. And just for all the attendees, feedback is such a gift. Please give us feedback about how you found this precision dosing seminar. And the other thing is, all of these talks will go up on our YouTube channel, provided everyone agrees to that. And so it can be really helpful, I think, for all the people who learnt so much today to go back and re-listen if you need to. So with that, I'll just say a final thank you, and I hope you have a lovely rest of the day. Bye, everyone.
Bye.